Hello, everyone, and welcome to tonight's webinar, The Future of PSC, Disease Pathogenesis, Oral Vancomycin, and Cancer Prevention and Surveillance. We have three excellent speakers who will be presenting on these topics that have been suggested by our patient caregiver community in personal feedback from our webinars, conferences, and surveys. A huge thank you to our community and corporate sponsors who support our 2022 conference series.
Good afternoon. My name is Konstantinos Lazaridis. I'm a professor of medicine and consultant in the Division of Gastroenterology and Hepatology at the Mayo Clinic in Rochester, Minnesota. I would like to thank you for the invitation to present to this group. And the title of my presentation today is New Prognostication Tools, an ongoing novel pathogenesis studies of primary sclerosing cholangitis. As of today, the knowledge gap of primary sclerosing cholangitis remains significant. We don't know what causes primary sclerosing cholangitis. We have, unfortunately, no reliable biomarkers for disease progression. The prediction of disease outcomes, particularly as relates to development of cancer and more specifically cholangiocarcinoma, is quite limited, and we lack an effective medical therapy to slow the progression of this chronic liver condition. At a very high level, the overarching hypothesis on primary sclerosing cholangitis pathogenesis and outcomes is highlighted below. We believe this is a disease that is affected by our hot genetics. We've done work over the last 2 decades to understand the genetic predisposition to primary sclerosing cholangitis, and we realize that there are a number of risk loci within the genome, but not a significant element that we can identify to be causative for this condition. At the same time, we believe that the environment we all live in it has significant contributions to development of this disease. Particularly, we believe that the interaction between our whole genetics and environmental exposures is critical to development of primary sclerosing cholangitis. And we believe it's this intersection, this dialogue of the genes and the environment that gives us the opportunity to develop novel tools to make discoveries of how we can better understand this condition in a way that we can develop novel diagnostics and therapeutics. With this in mind, about 5 years ago, we submitted an application to the NIDK to support our work, which we're currently pursuing. This graph shows you the overall approach for this grant application. We like to understand the interaction of environmental exposures, whether this is diet, pollution, bacteria, stress, medications, and many others, and how those elements interact with whole genetics in 2 compartments that we measure those effects in blood and stool. And then we like to use those, what we call peripheral and gut signatures, to correlate those with clinical data using AI to better understand how those elements contribute to the pathogenesis of disease. And this will become, we hope, the basis of novel therapies in the coming years. So along these lines, we've developed novel tools to better understand disease progression. And this is one of the publications we have been able to produce over the last few years. This publication describes a new score for the disease called the PRESTO score, Primary Sclerosing Cholangitis Risk Estimate tool, that predicts the outcomes of the disease over a period of time. And it's using biochemical parameters and history data of patients to see what will happen to patients over a period of time, particularly as related to hepatic compensation. I will explain this more. In this paper, we used what we call a derivation cohort from the United States and a validation cohort to replicate our results and findings from Norway. In the derivation cohort, we include almost 510 patients, and in the validation cohort, there were about 278 patients. By pursuing this type of work and using artificial intelligence, we found that the most important variables that contribute to this score, the pressure score, was total bilirubin, albumin, serum alkaline phosphatase, abbreviated as SAP, platelet AST, which is one of the liver transaminases, age of the patient, duration of primary sclerosing cholangitis, hemoglobin, and sodium. We also realized from this graph that one of the most important variables of the score, which predicts disease outcome, is not serum alkaline phosphatase, which appears to be third on the line, but is the total bilirubin and the albumin, which are much higher on this list of variables. So using this variable, we developed this score, which is now available publicly to everyone, and I'd like to highlight in the next few moments how you can use this link to bring this public algorithm to your availability to estimate the score of a patient who has primary sclerosing cholangitis. So if we click this link, it will bring us to the Mayo website that describes the score. We have to make sure that you understand this score does not apply to every single patient who has primary sclerosing cholangitis. Particularly, this score does not apply to patients who have small duct PSC. This score does not apply to patients who have a concurrent liver condition such as autoimmune hepatitis. Patients are eligible to use the score if they have a MELD score that is less than 14 at baseline. If someone has a liver transplantation, they cannot qualify to use this tool, as well as if they have evidence of portal hypertension as outlined here. And unfortunately, this score is developed. It has been created for individuals who are not pediatric patients. So if an individual has any of the above criteria listed, unfortunately, they cannot use the pressure score because it's not valid for that category of patients or this category of patients. And therefore, here then you have the criteria that someone has to enter. You have to enter the age of the patient. I'm going to put some numbers to be able to create a score. So let's say someone is 20 years of age. The alkaline phosphatase is about 250. It's critical to put the laboratory, the upper limit of the laboratory testing of alkaline phosphatase where this test was performed. So you can see many times that you get a value, let's say, of 250 for a patient, and in parentheses, there is a limit or a normal cut-off for this value. And let's say for this laboratory here, it's going to be 140, which is what is for our laboratory. We'll give a aspartate transaminase level of 56. We'll give a total bilirubin of 1.1, an albumin of 4, a sodium 144, a hemoglobin of 13.8, platelet count of 170. Duration of disease of 5 years. And then by clicking the last button, it tells you that this individual with those particular numbers at the present time will have a risk of about 6% to have decompensation of the liver disease over 5 years' time, and the prediction of the other percentages over years 2, 3, 4, and 5. So by looking at this graph, it seems like this individual will progress probably slightly over time, and again, this is a hypothetical scenario. But you can use this score, which is available, to estimate individual's score. And actually, you can calculate more than one individual at a time if you give some other variables. So if you have now an individual with another age, or the same individual with some different variables, you can again get an understanding of what the score may tell you. Again, I use some numbers that I'm trying to apply here to be able to see a graph of the score. Use these numbers that slightly different. They're more normal to the baseline, as you can see, because I use numbers which are more normal to the baseline. This individual has even, if you will, a better projection of disease progression to liver decompensation in 1 year, 2 years, 3 years, 4 years, and 5 years. The percent of having liver decompensation, the second individual is going to be lower than the other individual. And at 5 years' time, the percent of liver decompensation or the chance of the risk is going to be about 3%. So this gives you an idea of what this score can tell you. And also, if you enter the numbers for an individual or a patient, you can understand where they are in the present time and how they may present or what their score in 2 years from now. We think this can be very helpful for patients to understand disease progression from what we know today. At the same time, we realize that we still lack a reliable biomarker for this disease, and so we do additional work to understand for other biochemical elements that are critical to the disease pathogenesis. In this particular context, we believe that bile acids are important for this condition, and therefore we have this publication recently reported of how bile acids in primary sclerosing cholangitis can predict hepatic decompensation. For this particular work, we took into account what we know for some time, that people with cholestatic liver diseases, such as primary sclerosing cholangitis, they have an increase of the pool of bile acids. That's what happens in these patients over time because of the liver disease that affects the liver parenchyma. We know that bile acids are produced in the liver, and they're used for digestion of the food we all eat. And there is this continued recirculation of bile acids between the small intestine and the liver. And at the same time, there is continuous production of bile acids that are sometimes released to the environment through the stool. Because of the cholestasis, the damage of the bile ducts and the lack of proper flow of bile within the bile ducts and therefore into the intestine, there is a retention of bile acids in the liver, and this retention leads to high presence of bile acids in the bloodstream. The presence of the bile acids in high levels, particularly within the biliary system and the liver, creates toxicity to the patients and many other phenomena, including senescence of those cells and immune activation, which probably contribute to the disease pathogenesis and progression. Despite the fact that we know that bile acids are elevated in primary sclerosing cholangitis, there is very little detailed work on humans about the correlation of bile acids with disease progression, and that was the basis of our work for this particular publication. We included, as you can see here, about 400 patients and 300 controls, individuals who don't have primary sclerosing cholangitis. That was the initial assessment. We also used a replication cohort from Norway, again, to kind of confirm the results in a separate cohort. And we use time to meta-analysis, in particular hepatic decompensation defined by development of ascites, varicose hemorrhage, and hepatic encephalopathy, to be able to have some robust outcomes that we can measure using the clinical record or assess using the clinical record. We haven't used hepatic transplantation as an outcome because we know that sometimes the criteria used, particularly in the past, for liver transplantation of patients with PSC were not consistent among different medical centers. What we found, and not surprising, is that total bile acids are much higher in the serum of patients of PSC compared to controls, as you can see in this middle graph. We found also that the composition of bile acids among different types in PSC patients compared to controls is different. Primarily, as we know, patients with PSC, or a number of them take ursodeoxycholic acid, and therefore this particular bile acid is significantly more frequent in patients with PSC compared to controls. But more importantly, we found that for a number of time to event analysis, which is what we call early pathogenesis, a number of bile acids did associate significantly with decompensation, suggesting that bile acids are critical elements that they can be used to assess the disease progression as we assess it in this particular publication. And therefore, using this information, we create a PSC bile acid profile model that shows here. And this graph on the left shows you that 2-row-orthodeoxycholic acid is one which has the most relative influence on the model, and all the other elements of bile acids are shown, including age of the patient. But using now this model and this algorithm, which we will make it publicly available at some point in the near future, someone can use the composition of bile acids we find in the blood to predict disease prognostication, as someone can do by using the pressure score, which I highlighted earlier. The challenge, of course, someone will have with this particular score is that not many institutions can measure all these elements of bile acids in serum, and this can be quite limiting to be able to use this score in a public approach. Also, sometimes the patient may not have all these details of how to enter these bile acids into the score, and so that will create some limitation to do this at home, for example, if you don't have this data available. But importantly, we think that bile acid changes in PSC that are present and consistent with what we know may be the basis of understanding the mechanism of the disease, which then become relevant to devise new targets for therapy. We believe also additional work has to be done to use those bile acids as novel biomarkers for disease progression and hepatic compensation. And we think that bile acids should be used in clinical trials and in clinical care, so we have a lot of data for all of us to better further understand the contribution of bile acids in the pathogenesis of primary sclerosing cholangitis. Another element that we have started exploring over the last 2 years now is the effect of the environment and the progression on the pathogenesis and progression of the disease. We're using very sophisticated, high-resolution exposomics and metabolomics tools to identify novel chemicals or metabolites present in patients with primary sclerosing cholangitis. So in this particular paper, we used patients with PSC, with and without IBD, patients with primary biliary cholangitis and controls, to start understanding, are there any particular chemicals present in the bloodstream of patients with PSC, PBC, and how those chemicals affect metabolic pathways. We use a number of approaches. Some of those are targeted, which means that we were going after specific chemicals that we think can measure reliably. And as you can see here, between patients with PSC and controls, and among patients with primary biliary cirrhosis, biliary cholangitis and controls, there are for the most part different chemicals present. One of the most relevant chemicals among patients with PSC is a fungicide called fenpropimorph, shown here at the very top of the graph. It's not the only one, but it's the one that's very significantly associated with disease. It's almost 8 times more often present in patients with PSC compared to controls. And we'd like to study this molecule further. We have done also untargeted approaches where we measure different molecules with methodologies. We don't know what those molecules are specifically, and we take a lot of work for us to identify all those blue or red dots on the very left graph that shows the difference between patients and controls. But among those molecules, we found, for example, a chemical called terbucarb, which is prevalent in the PSC population. And as you can see, we found this, if you will, this footprint or spectrum, we call it, without knowing what molecule it is, and then by correlate this to what was the reference footprint to be the terbucarb, which causing liver disease in animal models. There's no evidence so far that causes liver disease in humans. But we like, again, as I said, as we do additional studies, to be able to replicate those results, to confirm those results, so we can go into more depth to understand the pathogenesis of the disease related to chemical exposures. At the same time, we want to study the different metabolites that are normally present in all of us and how they may be changed after the main difficult exposures. We realized that some of the metabolic pathways, which are quite relevant to PBC and PSC, are metabolites associated with steroid metabolism, bile acid biosynthesis, and vitamin D3 metabolism. Those are, again, observations. We don't know exactly what they mean, but we like to gather the data because we wanted to correlate how exposures and metabolic pathways are related. And this shows this particular graph here, where you can see at the center of those clusters, of those three clusters, there are chemicals, and how these chemicals affect the metabolic pathways that are present in all of us. This also tells you that how those particular chemicals and exposures affect the metabolic profiles of patients with primary cholangitis. Again, this is very interesting early work that we like to take to replication to be able to confirm those findings and start diving into more detail to understand what those findings mean and how we can use this information to better understand what contributes to disease and how we can find novel targets for therapy or ways for us to better understand the mechanisms of primary sclerosing cholangitis. Equally importantly, what I shared with you is not the end of what we're doing. We're doing a lot of additional work. At the present time, we have a large study we call the 1600 study, where we have, as you can see, several hundreds of patients with PSC, PBC, and controls. And we like to replicate the findings that we just shared with you. We think that will be significant to be able to reach to this conclusion and say that we can be able to replicate the number of chemicals that are associated with primary sclerosing cholangitis. At the same time, we like to understand how those chemicals affect the DNA epigenome and how those two elements work together to contribute to pathogenesis of primary sclerosing cholangitis. At the same time, we have an additional blood study, we call this the Gold 100, which has sort of a less number of patients as highlighted here, but we like to study immune cells within the blood of those patients. We like also to use different platforms to study exposure to metabolites. And equally importantly, we like to be able to use targeted proteomics to go beyond metabolites and chemicals to study the differences in proteins of those populations of patients. Again, novel data will give us a lot of new discoveries to better understand primary sclerosing cholangitis. Finally, as I said earlier, the stool compartment is also very important. We have now almost 1,200 patients to study from different groups of patients and controls. We like to study chemicals and metabolites in stool. This is very unique, particularly the metabolic profile of those stool specimens that nobody has studied in the past. And at the same time, we like to use those specimens that we have provided over the years to understand the different type of bacteria, what other chemicals and bacteria produce, including the fungal genome, which is something very important as we all understand in the coming, in the last few months or years. And therefore, One thing that I'd like to finish my talk is that there is a tremendous work and opportunity to learn more about this disease, and I'm confident that this novel information will give us all the elements we need to be able to reach, discoveries that will have impact on understanding and hopefully treating this condition in the coming years. Thank you for your attention, and as always, I'm very appreciative for your help of providing my specimens. I believe the discovery future PSC is bright, and in the coming years, we'll be in a better position to tell you what we can offer differently, how can we bring novel biomarkers, and how we can provide the basis for novel therapies for this challenging condition. Thank you for your attention. Thank you.
Hello, everyone, and welcome to this evening's webinar. I'd like to first thank PSC Partners Seeking a Cure for allowing me to speak on the topic of oral vancomycin in PSC. I'd also like to thank Dr. Korzenik for moderating this session, and thank also my fellow speakers during tonight's webinar. My name is James Tabibian, and I'm very pleased to be able to speak to you all about this topic. I'm happy to say I have no relevant financial disclosures or conflicts of interest. I will confess I am an advanced endoscopist, which means that I really don't spend any more time at the basic laboratory bench, although I do have that background going back some years. And I also want to say from the outset that I'm not specifically pro or anti-vancomycin for the treatment of PSC. I consider myself pro-patient and pro-science, and sometimes that leads me to lean in favor of oral vancomycin, and other times not. So tonight's objectives in this presentation will be to provide a brief overview of the gut-liver axis as relevant to PSC, describe what vancomycin, or vanco as I might call it, is, review at a high level the pros and cons of oral vanco as a treatment for PSC, and identify some potential future directions in vanco research. So let's get into the gut-liver axis. As many will know, the gut-liver axis is now really appreciated for playing a role in health as well as in disease. Gut-liver interactions are very complex. There is an intricate interplay of interrelated and moving parts. These interrelated and moving parts include host genes, such as the genome, but also the epigenome, the environment, which includes xenobiotics, diet, medications, and so forth, the enteric microbiome, which includes microbes and also microbial metabolites, and others. The intestine, sometimes I'll call it the gut, the intestinal microbiome and gut-liver axis are increasingly recognized as important for liver health and homeostasis. So both really for the organism or for us as a whole, but also specifically for the liver. And it's been appreciated that perturbations in the microbiome or the intestinal microbiome may initiate and or modify certain liver diseases, including PSC. So what is the evidence of there being a gut-liver axis in PSC, or evidence of it being relevant? Well, several lines of evidence. PSC cholangiocytes, or the cells that line bile ducts, also called epithelial cells, accumulate lipopolysaccharide, LPS, which is a bacterial surface molecule, and they're also hypersensitive to it when studied in vitro in laboratory experiments. The PSC inflammatory bowel disease, or IBD relationship, is another piece of evidence. This relationship is extremely impressive, with nearly 70% of patients with PSC also having IBD. It's almost unheard of, at least in gastroenterology or liver disease. The associations between PSC and genes, or genomic loci, speaking technically, involved in host microbe host microbiome interactions, such as fucosylotransferase 2 and also the interleukin 2 receptor, are also another line of evidence to suggest the relevance of the gut-liver axis in PSC. And model systems, whether they are in vitro or animal models, as well as clinical trial data, point to the role of the microbiome and antibiotics and globally the gut-liver axis in PSC. In addition, and as appreciated in more recent years perhaps, there are alterations in the intestinal microbiome that seem to be unique to PSC. So just one slide on this last point. Patients with PSC have a marked decrease in intestinal microbial diversity. There's also intestinal dysbiosis, or in other words, an imbalance in the bacteria and also their metabolites, and in how bacteria interact with the host, our body or our intestine. So I won't go into all these details, but they're here provided on the slide. There's overrepresentation of several different genuses or genera of bacteria compared to both healthy controls as well as patients who have IBD alone, in other words, IBD without PSC. And conversely, there's reductions in certain genera compared to healthy controls and to patients with IBD alone. So next, let's get into what is Vanco? What is vancomycin? And actually, this is, I think, something that many physicians also might not know, at least not off the top of their head. So Vanco is what's technically considered a glycopeptide. Specifically, if we want to get more technical, it's a 7-membered branched tricyclic non-ribosomal peptide, which also has a disaccharide glycosylation on residue 4 at the top part here of the molecule. Simply stated, it's a peptide or a protein with a carbohydrate group, hence the glyco in the name, that's attached to one of its amino acid side chains. Interestingly, Vanco was isolated in 1953 by a gentleman by the name of Edmund Kornfeld, who was working at Eli Lilly, from a soil sample collected from the Bornean jungle by a missionary, Reverend William Boo. The organism that produces vancomycin was ultimately identified as and named Amycoleptopsis orientalis, a soil bacterium. So what is Vanco used for? Broadly speaking, it's an antibiotic that's regularly used to treat various bacterial infections. It acts by inhibiting cell wall synthesis in gram-positive bacteria, and it can be administered either intravenously or enterally, such as by the mouth or through the mouth, depending on the nature of the infection. So intravenous vancomycin might be used to treat skin infections, bloodstream infections, endocarditis, meningitis, and various others due to methicillin-resistant Staphylococcus aureus, or MRSA, as we call it. Enteral use is typically for the treatment of C. diff, or C. difficile colitis. And when it's used enterally, there's virtually no absorption into the bloodstream, which can be a beneficial aspect. Now, these are just some general basics. There are some data that suggest Vanco has other actions as well, or works by other mechanisms as well, but that's beyond the scope of tonight's webinar. So I think what many folks will be interested in here in particular are the rationale, pros, and cons of Vanco and PSC. So from my perspective and that of many others, the rationale for Vanco in treating PSC can be summarized in this slide as follows. The biological plausibility of the microbiome being associated with or playing a role in PSC pathogenesis. That's one rationale. Also, the interdependent relationship between bile acids, commensal microbiota, the good microbiota, so to speak, and C. difficile. C. difficile, of course, is responsible for transforming primary bile acids into secondary bile acids and is a target of Vanco. So it kind of makes sense. There's biological plausibility here. But in addition, Vanco is not unique as an antibiotic for having shown to have beneficial effects in PSC. And there are a number of references here on the bottom right, but in a recent meta-analysis or systematic review, it was noted that in PSC patients, antibiotic treatment results in a significant improvement in markers of cholestasis and Mayo risk score, and that antibiotics, particularly vancomycin, may have a positive effect on PSC either via direct effects on the microbiome or via host-mediated mechanisms. So we spoke just now about the rationale for PSC at a high level. What are some of the pros of Vanco in PSC? Well, there are many. And I think perhaps the earliest are the many success stories that date back over 20 years in treating patients who have PSC and IBD with Vanco. And these success stories are take on different forms, let's say, but importantly, they're not just anecdotal or just case reports. There's been actually randomized clinical trials, prospective cohort studies, retrospective studies, and others. And the reported benefits of Vanco, which I think are really important in PSC, as opposed to, say, maybe more so with PBC, are that so the reported benefits aren't only biochemical, which is important because we don't really have a perfect or a really high fidelity biochemical biomarker, if you will, in PSC. But what's good is that, or what's been reported is that there are cholangiographic benefits, colonoscopic benefits or improvements, histologic improvements, and symptomatic improvements. So I think this makes a compelling case that at least in some patients, Vanco is really doing something important. It's not just making a few labs look a little bit better. The other pro, of course, is that it's generally very safe and well tolerated. Certainly some patients will have Vanco-related diarrhea, fatigue, or weight loss, but and itching, but these usually abate within a few weeks or with slow dose titration. This slide, I think, is important because it's valuable to bear in mind that there are differing levels of evidence in research. Both the table in the upper right as well as the pyramid here on the lower left demonstrate that really the top of the pyramid, the highest quality of evidence, comes in the form of systematic reviews and meta-analyses, and specifically meta-analyses of randomized controlled trials. And this is an area where things are lacking as far as the role of Vanco in PSC. That being said, other levels of evidence, are there, but usually the more the better, since really no two patients are alike. So, as I just alluded to, one of the cons of Vanco for treating PSC is that there's a very high level, there's a dearth of level 1 quality evidence. In addition, going a bit deeper, I conceptualize the cons of Vanco for treating PSC into 3 categories of concerns. These categories are at the level of the patient, at the level of the drug or the medication, and miscellaneous. So I have a slide on each one of these 3 categories that we'll go through now. So patient-level concerns regarding vancomycin and PSC include, well, which patients should be treated with Vanco? All patients with PSC, those with symptoms, those with biochemical abnormalities, those who don't have cirrhosis yet, those who have PSC and IBD, but not just PSC alone. We're not sure. And then what if a person's on Vanco, but there's no benefit after 3 or 6 months, either in labs or symptoms or what have you? Do you stop the medication? Should you keep it going for another 6 months? Should you increase the dose? We really don't have very good parameters or guidance to go by. And then what I think can apply to almost any medicine, is the false sense of well-being. So let's say someone is taking Vanco and labs improve. Well, does this really mean that there's going to be benefits in terms of hard endpoints? So we know that, for instance, even in patients with PSC whose alk phos improves, you're not really out of the woods just yet. So, it would be a shame for someone to stay on Vanco and not embrace other potential therapies that might come down the road, thinking that they're doing much better on Vanco, when in reality there's still damage going on to the body, to the liver. So drug level concerns regarding Vanco and PSC include, well, what dosing is best? And how many milligrams per day? How many times per day? Does it really make a difference? Can you just take it all at once? And then for how long? Should you be on Vanco lifelong? Do you stop and then retreat if it seems it's needed, maybe because labs worsen or symptoms come back? Should you just cycle on and off, maybe 1 week on, 1 week off, or 1 month on, 1 month off? We really don't know. And then also, as I've kind of alluded to before, what is the best endpoint or biomarker to follow? We really don't have a great one in PSC. So should we look at alk phos change or ALP change, patient-reported outcomes, MRCP findings, colonoscopy findings, maybe a composite endpoint? I think it's anyone's guess, but certainly the more endpoints that we look at, and the more endpoints or biomarkers improve, I think the more convincing the effect of Vanco would be. Of course, there's also the question or concern about, well, which manufacturer of Vanco should I be using? And there's some that seem to be more effective, and some that seem to be less effective or really haven't been that well studied. So this just kind of introduces a lot of variability or confounding that can make this assessment more challenging. And then the third category that I mentioned was that of miscellaneous concerns. So one of them would be selecting for resistant bacterial organisms, in particular VRE. This is a theoretical concern that can impact not only individuals, but also society, but really hasn't been borne out from what I can see, at least not to any clinically significant or statistically significant degree. Insurance coverage. Some insurance carriers will just say no because it's experimental or it's not indicated. And there can be a battle there that needs to be fought. And it can be tough and very fatiguing. There's also provider issues. Not everyone or not every provider is willing to prescribe Vanco, and many providers don't really know how to follow patients who are on Vanco. Like what should you be looking at and how often? Because Vanco is not FDA approved for treating PSC and is perhaps, one might say, a contentious topic or an arguable topic in the field, there may also be some medical legal concerns among providers with prescribing Vanco, and if something goes wrong, for instance. And then I think another concern is that the use of Vanco outside of a clinical study really detracts from what we can learn about PSC and the effect of this drug in PSC. So if everyone is kind of doing their own thing on an ad hoc basis, that's potentially a large body of data that is kind of lost because nobody is aggregating it, nobody is organizing it and analyzing it. It's just kind of piecemeal and detached, which is unfortunate. So in this last section, I'll just mention a few future directions in Vanco PSC research. So I think it would be useful to continue trying to understand the mechanisms of how vancomycin may impact the microbiome and PSC, and really both in animal model systems as well as in humans. I also think we should put our heads together as a community and come up with an algorithmic approach to pharmacologic treatment of PSC. So for instance, if you have PSC and XYZ criteria are met, you do this. If that doesn't work or you don't tolerate it, then you do this. And then if everyone kind of follows the same general algorithm, then I think it will help shepherd people towards clinical trials. It will help shepherd people towards a more uniform approach to vancomycin and so forth. And I think we can just glean much more from that rather than, as I had said just a few moments ago, everyone kind of doing their own thing at a certain dose and so forth. I think the big need here is more randomized clinical trial data, larger studies, longer term studies, looking at also the brand and of Vanco. And I think when that's not possible, at least some more open label studies would be very valuable. So in summary, PSC is a hallmark disorder of the gut-liver axis. The microbiome seems to play an important role in this disorder. There is promising experience and data thus far with oral Vanco in PSC. However, not all studies have been positive, and there are still many, many unknowns on a variety of different levels. Further research is certainly needed to fill in the gaps regarding Vanco, as well as to develop treatments for those who don't respond to Vanco, in addition to studying other aspects of how to best treat PSC. Thank you very much for your attention.
Hello, my name is Greg Gores. I'm a physician at the Mayo Clinic in Rochester, Minnesota. I want to thank the PSC Partners for Cure for the opportunity to participate in this webinar. I've been asked to speak about the future of PSC diagnosis and management with a focus on cholangiocarcinoma surveillance and prevention. Primary sclerosing cholangitis, as we are all aware, is an inflammatory disease of the bile ducts within and outside the liver. Approximately 75 to 85% of patients will have inflammatory bowel disease. This is a premalignant condition, and unfortunately there's a lifelong risk of cholangiocarcinoma of 10 to 15%. This is a very interesting study from our colleagues in Europe in a community-based approach. Looked at when does cholangiocarcinoma occur in the course of a patient with PSC. 26% occur in the first year when the patients are often co-diagnosed with PSC plus cholangiocarcinoma. A third occur in the next decade, and then a third thereafter. So the risk persists throughout the duration of PSC, but is not necessarily related to the duration. The American Association for the Study of Liver Disease, or AASLD, issued a guidance document in 2023, which will be published in Hepatology in February of 2023, but which is online now. In that document, they state that cholangiocarcinoma and gallbladder carcinoma surveillance should be performed annually and include abdominal imaging, preferably by MRI and MRCP, with or without a serum CA19-9. The data for that recommendation come predominantly from this paper, which looked at overall survival for PSC patients who had annual imaging versus those who did not undergo annual imaging. The dark line, or solid line, is those patients who did not have imaging, and the dotted line is those patients who did have imaging. There was a drastic increase in survival in patients who had imaging. This was predominantly because the patients were diagnosed early with cholangiocarcinoma and had the option of liver transplantation. So what is the goal of imaging? The goal of imaging is to determine whether a stricture looks malignant or not. This requires considerable expertise, particularly in inflammatory stricturing disease such as PSC. The ASLD now uses the term relevant stricture. And the question is, does this look tight? And are there consequences? Is there a mass lesion around it? Is there atrophy or shrinkage of the area upstream of the stricture in the liver? And if there is a vascular encasement, or what we would say wrapping of the inflammatory process around a blood vessel, that would be a sine qua non of malignancy. Serum test for CA19-9, I will review in detail. And if these tests are worrisome, then that would prompt an endoscopy with an endoscopic retrograde cholangiography with brush cytology. This would be such a patient which I recently saw at the Mayo Clinic. 60-year-old female. She's had her colon taken out for inflammatory bowel disease with the ileal pouch anorectal anastomosis. She's had PSC for 12 years. As she comes just for her annual surveillance studies, she feels well. The CA19-9 was over 1,000 units per milliliter. Although the MRI detected no mass lesions, on ERCP, the brushings from the bile duct were worrisome for cancer, which I will go into great detail, and she is now being evaluated for liver transplantation. When the endoscopist or the person performing the endoscopic retrograde cholangio procedure does the ERCP, they insert a brush inside the lumen of the bile duct. They're able to collect cells from that brushing, put them on a slide, and then the pathologist can look at those cells. You can see here this is normal, atypical cells, suspicious cells, or cells positive for malignancy. But you can appreciate that the differentiation is subtle and difficult. Indeed, the sensitivity is only around 20%, so it misses 80% of patients with cancer. And this is often because these are scarring cancers. There are very few cells for the pathologist to evaluate. Yet a positive cytology is still the gold standard. In other words, if it's positive, the patient has malignancy. We have pioneered the use of fluorescence in situ hybridization, and the ASLD guidance document now endorses this approach. You inherit 23 chromosomes from your father, 23 from your mother, and therefore you should have two colors in this assay for each chromosome. If you have more than that, it's indicative of chromosomal instability. And chromosomal instability is a hallmark of malignancy. So if we see more than two signals per chromosome and two or more chromosomes, we term this polysomy scientifically, and I will refer to this term going forward. What do we know about polysomy? Well, at our institution, standard cytology is only positive in about 20% of patients with malignancy, yet it's a gold standard, being very specific. We have tripled the value of fish. With fish, we have tripled the value for identifying cancer at 65%, yet maintain high specificity. So this is the algorithm from the ASLD guidance document. Shows that if somebody has an MRI or MRCP with a worrisome stricture or an elevated CA19-9, this would prompt an ERCP. So we know that patients with CA19-9 values greater than 130 units per milliliter are at risk for having an underlying malignancy. I will note that about a third of PSC patients have values in this range, but without cancer. So it's only about 60 to 70% specific, yet 60 or 70% specificity is quite high when you're talking about malignancy. We know that people who have an elevated CA19-9 plus polysomy almost all develop cancer in 3 years. I apologize for not having the numbers on this axis. We know that if there's polysomy with a normal CA19-9, it's only about 60% have malignancy, and if both tests are negative in the absence of a mass lesion or other worrisome features, it's very unusual that people will develop malignancy. So polysomy plus a high CA19-9, like the patient I just presented as an illustrative case, virtually all will develop cancer in 3 years. So we know that in this algorithm, if you have a biopsy positive and cytology positive for cancer, that's diagnostic. If everything is negative, one can go back to routine surveillance, perhaps maybe an early recall with an MRI if there's concern. And we know that the cytology is negative, but the fish is positive with a high CA19-9. The patient likely has cancer. If the fish is positive, we like to repeat it over time. And I'll show you the data for that. So these are patients who have a normal CA19-9 and one test positive for polysomy. Because it's a test, we sometimes like to repeat the test over time to see if it remains positive. In patients in whom the test remains positive within 5 years, 80% will have cancer. In those patients who we cannot confirm polysomy, we only have one test positive, almost none of them develop cancer after a year. We also know that we can find the polysomy in multiple places in the bile duct, likely reflecting a high degree of cellular abnormalities and chromosomal instability, that the likelihood they have cancer is quite high, again 80%. If we can only find it in one location, it is less worrisome, and only 20% of these patients will develop cancer in the first year, and very few after that. So when we're doing this brush cytology, we like to brush from several areas in the bile duct so we can determine if the abnormality is widespread or not. If it's widespread, equals malignancy. If not, less worrisome. So, and what if the cells are suspicious, cytology is suspicious, but the fish is negative? Well, actually, the suspicious cytology in patients with an inflammatory condition like PSC is not so worrisome. And so here we would simply repeat the ERCP in 3 months, and if the fish remains negative, we probably would just go back to imaging with MRI, MRCP. The data for that are as follows. So the graph on your left shows that they're suspicious cells. Perhaps we should be very concerned in the first year, but thereafter, very few patients develop malignancy. And in the absence of polysomy, as shown in the figure on your right, very few patients will develop malignancy after the first year. So what about the future? Why do some people get this 10 to 15% and others do not? I think we will learn a lot in the near future about patients who have genetic predispositions to cancer. We now know that outside of PSC, that 1 in 8 patients who has cholangiocarcinoma or biliary tract cancer has inherited a mutation from one of their parents that predisposes them to cancer. This graph shows the different types of genetic abnormalities, which is growing, and the exact abnormalities are not important for this discussion. What's important is that inheritable mutations are common, predispose people to cancer, especially in PSC. I think this will become important in terms of stratifying who needs careful and maybe perhaps more invasive follow-up, as I've shown in this slide. Let's say in the future you have a genetic sequencing and you're found to have a germline variant that predisposes to cancer. that person may wish to have annual ERCP with bile duct cytology, like you would have colonoscopy if you have inflammatory bowel disease with PSC, to get the biopsies and the brushings. But if your germline is normal, you have no mutations, maybe then you can go back and just do MRIs and blood biomarker studies as highlighted by the current ASLD guidelines. Finally, what can we do to prevent bile duct cancer? And I would suggest that one of the pharmacologic approaches we may have is the use of statins. Statins are medications which are used to lower blood cholesterol in people who have high blood cholesterol and are at risk for cardiovascular disease. They're well tolerated and widely prescribed. In population studies, the use of statins is associated with a decreased risk of bile duct cancer or cholangiocarcinoma. There are 7 papers now largely showing this, and the large diamond here on the bottom of this graph shows that the risk is reduced because it's to the left of the line if one looks in aggregate at these studies. We don't know a lot about statin use in PSC, but my suspicion is that we need to investigate this rigorously, and perhaps we need to start entertaining the use of statins to decrease the risk of cholangiocarcinoma in patients with PSC. So in conclusion, I would say that non-invasive surveillance is recommended in PSC patients with MRI, and I use the CA19-9 annually. I think in the future studies, we'll be talking about chemoprevention with statins and stratification of patients by genetic sequencing, looking for inheritable mutations, which will intensify the surveillance strategy. Thank you very much, and I greatly appreciate the opportunity to participate in this webinar sponsored by our colleagues in the PSC for Cure.